Recording. Good morning, everyone. This is the May 20th, 2025 meeting of the Behavioral Health Committee for the Incarceration Prevention and Reduction Task Force. I'm Stephen Gockley. I've been a co-chair with Dan Hamill. Dan is otherwise engaged this morning and won't be able to attend. We'll start off with the land acknowledgement statement. Before we begin, we acknowledge that we are gathered on the traditional and unceded territory of the Lummi, Nooksack, Samish, and Semiahmoo people who have cared for and tended this land since time immemorial. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We pay respect to their elders, past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us together here today. And please join us in uncovering such truths at any and all public events. So I'll call the meeting to order. We do have a quorum, and the first item on the agenda is the election of a co-chair. I've had the honor of serving as co-chair for the committee with Dan, sort of half a step behind Dan, very appreciative of his leadership for over a year now. And I think it's my time to pass the baton. So I am very shortly resigning as co-chair, and we've been really fortunate to recruit Brian Estes to put himself forward to take on that co-chair role with Dan. Just to speak on behalf of Brian, you know, he has NAMI connections. He's been a longtime member of this committee and otherwise involved in behavioral health advocacy for quite a while. I think he brings a different and important skill set to the committee. His experience will stand us in good stead, and he is ready to hit the ground running. So I do believe, and Jill, correct me if I'm wrong, I do believe we need to open the floor to other nominations, but I would initially be looking for a nomination for Brian to serve as co-chair of the committee. Are there any other nominations? I see none. Is there someone ready to nominate Brian as co-chair?
I would nominate Brian as co-chair. Mike Hilly here.
Thank you, Mike. Is there a second for Mike's motion?
I'll second Cedric Johnson.
Thank you. Okay, moved and seconded to install Brian Estes as co-chair of the Behavioral Health Committee. You may, let's have the vote. You may either raise your hand virtually or raise your hand on the screen, and Jill will tally the votes.
I guess I can vote for myself.
Yes, you can. I would hope you would. Okay, Jill, that looks like we certainly have a favorable vote.
We do need to ask anyone opposed, please
Yeah.
raise your hand or speak up.
Those opposed? I see none. Any abstentions? Very well. I believe that's a vote in favor of Brian to take over as the co-chair, and forthwith I'm turning over the gavel to Brian to run this meeting. Congratulations.
Thank you, Stephen. I wanted to thank you, Stephen, for your leadership over the past year and your leadership, of course, on the overall task force for many years. I think it's going to be a difficult shoes to fill. I will try my best, and I'm sure I'll be reaching out, Stephen, for a little advice from time to time. And I know you're going to be involved with the Behavioral Health Committee, overall Behavioral Health Committee of the county. So I'm sure we'll be crossing paths. So thank you all for your vote of confidence, and I'll do my best along with Dan to keep us moving forward and tackling very important issues related to behavioral health in our criminal justice system. So with that, I think our first agenda item is from Heather Flaherty about the Diswallop Clinic visit. And I should mention that yesterday I was on a call with a bi-monthly behavioral health and crisis responders meeting, and I with I'm forgetting his name from the Diswallop Clinic, but he's our outreach coordinator, and he and I developed a flyer on the clinic, which I think Jill is going to send to you all. So with that, I'll turn it over to Heather Flaherty.
Good morning, everybody. Heather Flaherty with the Chuckanut Health Foundation, but here today as a citizen representative and co-chair of the Incarceration Task Force. I see Stephen Traff. You went to the Diswallop Clinic as well, I believe, and I invite you to share with me today. I just have an informal report to just tell you about the field trip that we took to go see this clinic. Can you raise your hand if you've gone and seen it? Anybody? Mike Hilly, you have. Melora, you have. Tori. Well, all of you are welcome to chime in. And I was invited to share more, I think, because your committee is really focused on the Division Street campus and policy and ideas and innovation around the behavioral health services that we need to fill in the gaps in Whatcom County, and how we can really maximize this opportunity of a jail and public health sales use tax over the next 30 years. So I will share a few highlights, and then I invite anyone else who's gone to the clinic to also chime in. First of all, the clinic is beautiful. It is smaller than you'd expect, but every detail is really intentional, down to the colors of the walls and the tile and security guards standing out front. They have all, and I'll come back to why I said security guards, because normally that would probably sound like an unwelcoming detail, but their culture is so beautiful that the security guards know people's birthdays. They get to know people as they're coming in, all of the clients. They notice if somebody looks like they've had a bad day. They notice if somebody's, come in with a new car, or if they have balloons in their car, they'll check in on the kids. And it's just the culture. I think those are two big things for me. It was just the culture of the employees there, and then the intentionality of every detail of design. And the third highlight, I think, is just the human-centeredness that it seems to operate with. Now, granted, I only went for a 2-hour tour, so I'm not there every day. I can't tell you every detail, but the co-location of services, they have the, of course, the medicated assisted therapies. So people go there to get Suboxone and methadone. But they also treat the whole person. And so there's a primary care clinic there. There's a dental clinic there. There's case management. There's mental health counseling. There's on-site childcare. So you can bring your kid and drop them off for the time that you need to be there. There's gambling counseling. There's group therapy. There's art therapy. And so it's just, and there's even a van. So if you need transportation support, you can get signed up to get picked up and brought to the clinic. That is really different, I think, than, I'm not sure anything like that really exists in Whatcom County. Melora, you would know best, but I mean, Unity Care comes close. There's a lot of co-location of support at Unity Care, but the way that this culture seems to just make it about the whole person and not about the regulations and the rules, or my service stops here and insurance won't cover that. It's just, what do you need and how can we help you to get the best outcomes? And knowing that you can't just treat medically assisted treatment without also addressing that somebody might have tooth pain or that somebody has a cold that day. One big fact that the director of the clinic shared with me that was astounding was their embrace of harm reduction. And what she meant by that is the medical model that she started with at the Deidre clinic was it was more punitive based, more court based, that if you come in and you have you've used again, that you're going to get punished, you're going to have something taken away from you. And she said the turnover, Stephen, correct me if I'm going to ballpark it, the turnover at that time was like 68% or 70% high turnover rates. And she worked hard to shift to more of a harm reduction model of, okay, so you slipped up and used, but that's a part of recovery. And the attitude of if somebody's 10 minutes late, it's not, okay, well, it's too bad you're late, but it's, oh my gosh, we're so glad you're here. Let's see how we can help you. It must have been hard to get in this morning. Can I sign you up for the van service? And just that total shift, she said that turnover reduced over time to, I think, 12%-ish. Giant reduction because the staff got to actually care for people in a meaningful way, that they got to see outcomes in a different way too. And I think probably shifting from that punitive to more care-based and human-centeredness, also the kinds of people who apply for those jobs shifted over time as well. And I was really I'll share one more anecdote and then open it up to others who have gone. I was so taken aback by one story where there was a person receiving services, and they get scheduled for the whole, portions of the day, right? They can do all things at the same time. And there was a staff person who just observed that this person seemed a little sad, a little down, the energy was a little off. And the staff person just went up to them and said, "Hey, just wanted to check in, see how things are going." And the client said, "I'm fine. Everything's fine." A couple hours later, they check in again. They say, "Hey, I see you again. I just want to make sure everything's good. How are you doing today?" "I'm fine. Everything's fine." And then another time they see them when they're about to leave, maybe, or a little bit before they're going to leave, and they say, "Hey, just wanted to say hey and hope you had a good day and checking in on you." And the person finally shared, "You know what? I had plans to go home and commit suicide today. And you're noticing me and caring about me and checking in on me. I'm not going to do that anymore. And I just want to thank you." And the person who told me this story had tears in their eyes. It was so impactful, and it impacted me because I feel like maybe it's just the bubble I live in, but how little we really stop to look at each other as humans and address each other and care, even on calls like this, right? And what a huge difference that can make, and the beauty of that culture of just, we care about people, we love people, we want to see people's success, and we're going to do the things that make sense to make that happen. And the power of that. So I offer those anecdotes in sort of a disorganized way, forgive me for that, just to hopefully help us all think about all of those elements as we are engaged in these different design discussions, different policy discussions. And I know and believe that all of your hearts are so open, you wouldn't be here otherwise. And so I'm sure you're exactly aligned with that kind of feeling. And I just love that we saw where somebody's actually done that. And so we know we can do that too, and we can build like that too. So Stephen, you were on that field trip. What would you add for this committee to be thinking about?
Yeah, I mean, you kind of hit everything on the nose. I think the main thing that really stood out to me when I was down there is they got the right people in the right positions. You can give as much money towards something but unless you get the right people in place with the right skill sets and the right like motivation behind it, it's not going to go anywhere. And when you give a blank check or you basically fund something, sometimes it doesn't really go anywhere unless you have people in place that know what they're doing, and they really have people in place that know what they're doing, have the background, the experience, and have been there long enough that they build on what they currently have. And kind of to go off of one thing that you said is they've really focused on the fact that when someone's outward appearance improves, it really helps inward. And so with that medical and the dental, and really the dental, they really emphasized that people feel like they're getting back to who they were before things got rough or before they made certain decisions in their life. They've really focused on person-centered there, that they're looking at the person individually and isolating, kind of improving them from top to bottom, and not making them feel like they're just a number. And with how their old model was, where it was punitive, I think a lot of people felt like they were just a number. And now it's their turnover rate so low that it really proves that people are coming back because it's a safe place for them. Yeah, that's kind of all I wanted to add to what you were saying. Yeah.
Thank you. One thing that you reminded me of is even for the medically assisted treatment, just this one difference. They designed, instead of a counter where there's nurses behind the counter and people just line up, they have little rooms. So you open a door and there's a tiny room and then there's the counter. So your space has a door. And that actually, just that simple change allows that client to share things that they might not have shared when there's a big giant crowd behind them of people that can hear them. And that nurse can develop a relationship with that client and support them socially and with different mental health supports, and actually start to address some of those root causes of why they might be there in the first place. That's a detail that somebody that's going to build whatever we're building in the next 6 years should remember and know that, oh, let's have a door for these counters, right? So, Melora, what would you add for the good of the committee?
I would just add that Digwal Leach has had a really beautiful vision that I think is shared by a lot of our regional tribal partners. And they have done a really significant job in figuring out how they can serve the whole community. Swinomish is very unique in that they can serve more than just tribal members. And it's one of the reasons why Whatcom County chose to use one of our spaces for the division clinic. And we moved a lot of things around to do that because it is such a significant model. And I think that it illustrates what whole person care really is. And we're really lucky to have Swinomish offering the service in our community. I think it also has highlighted everything we're doing is a continuum. And so how do we link, Lummy's new methadone clinic to people who might be better served at Swinomish? How do we make sure that our teams are leveraging any of the services that we have, and then, really focusing on where maybe some of the pain points are. And what I will say is that Digwal Leach leadership has been so wonderful to work with. They've been so generous, so willing to step into this space and try to figure it out. And that is really the spirit that I think oftentimes there's a lot of overwhelm in our community providers. Brian mentioned our bi-monthly behavioral health and crisis services provider meeting that we had yesterday. And, agencies are really struggling and challenged with kind of the financial Medicaid reimbursement model that we have in the state, and the connection to the way that Medicaid is issued. And so I think Digwal-Leach gives us also this other way of doing things outside of the way that Medicaid functions for non-tribal partners, and really to me highlights how do we advocate at the state level to change the Medicaid landscape for our local providers that are non-tribal, so that they would be able to step into spaces like that. I do feel really confident that having Digwal-Leach now in this community actually kind of raises the bar around how we want to do healthcare for really our most vulnerable community members. And I'm just grateful. Like, I'm grateful that they're in our community. I'm grateful that this gift has been given to Whatcom County and our residents. And how do we then look at some of the challenges that our local providers have that are unique to them, that are different for Swinomish. So to me, it really highlights the kind of the system challenges that we have, because, right, because we see what can be done when you have the resources and the vision. And so it is really, it's very inspiring. And I am, again, very grateful, because I think it creates momentum within this group and other groups to make sure that that's the type of care that we're able to provide. And I would just, call out, you mentioned Unity Care, the Way Station Health and Hygiene Center is an example of a agency saying, we're going to step into something that FQHCs normally don't do. And right. And so I think that's what we're hoping, is that all of our providers would be able to start thinking innovatively and creatively, because that's what we need. And instead of this scarcity model where we're always in overwhelm and trying to make ends meet. So I know that is a little bit of a shift, but I'm just extremely grateful and very excited that we have more services in this community and that we're highlighting whole person care.
Melora. Tori and Mike, you two had gone before too, I think. And if there's anything you want to add about your observations or what you think this committee would benefit from knowing, and then I'd love any questions or dialogue.
Thanks, Heather. I would just echo everything that's been said before. It was a super heartwarming feeling to go out to that building and just see what's going on in there. And I got to lay at least from my perspective, Leon is the hero over there. I mean, he served in a high leadership role in that Swinomish community forever and took this on sort of after kind of a retirement aspect for in his own life. And you can tell the passion is just overwhelming for what he does. And so, yeah, I've toured the facility over in Anacortes, and then the mobile medical van over here, and everybody around it is just so welcoming. It's just a whole different approach, a great model. We need to continue lifting that up and supporting that in the community, because this was the missing piece, I think, at least for EMS, in the version model. So as we talk about rolling out buprenorphine in the street here really soon, now this is one of the puzzle pieces that comes together to keep people sort of engaged, and that idea of the warm handoff for success. And I'll say one thing. My colleagues down in South Snohomish just offered buprenorphine. They've been going about 3 months now. A little bit old news, but when they had reported to me, there were 80 inductions of buprenorphine in the field. 70% of them went to that next phase, the bridge prescription, and then the next dose. And a small amount actually went on to recovery. I want to say it was like 7 or 8%. So it's a small number, but it does represent what all of this continuum is of trying to get people to help. And for EMS, that's a win. That's a life saved. Whether they went in recovery or not, that was a person that didn't redose in 48 hours. So I think this Digwal-Leach here and the other future thing coming up are really the foundation for success in these programs. So, but yeah, no, I love those people. They're great.
Thanks, Mike.
Yeah, I being a dinosaur drug treatment counselor, meaning I've been doing this since about 1988, somewhat in Whatcom County and some in Alaska. Now I'm back, but for those of you who don't remember, I the program coordinator at Whatcom Community College, where we train people to be drug and alcohol counselors, and been acquainted with the folks at Digwell Leach for some time. I believe time flies really fast, but they got their start, I want to say, almost 10 years ago, and been down a couple of times in between when they added on to the building. And Digwell Leach is known and throughout the country as being a premier program, truly integrated services. And they've had people from across the country come and ask them how they can replicate their model. And like a lot of places, they have their growing pains, you know, particularly with trying to staff a program with the right people. And the right people can be trained in a lot of ways that we really try to focus on. You described a beautiful trauma responsive care clinic, you know, when they moved away from the punitive stuff, and any services that we do anywhere in the continuum would benefit from that. Having that, what is trauma responsive care? What does it mean? The other thing I wanted to share about this is that up until just a few years ago, Washington State mandated that drug treatment centers have abstinence only programs. They were abstinence based. And it wasn't until we started to bring in Suboxone and having that happen that we've all kind of inadvertently converted over to a harm reduction model. But I also want to make sure that we give voice to people who can sort of balance out you know, what is appropriate application of harm reduction versus enabling. And that's not an easy line to draw. It's really individualized. And so I appreciate Digwell Leach really kind of embracing what the ASAM criteria is asking us to do. And that is, you know, make space for harm reduction, make space for how we can help people without it's spilling over into the rest of our communities. The last thing I'm going to say about Digwell Leach is this. I'm really glad that they're in the community, and I'm glad that everybody is really noticing. But the other thing that I'm noticing is that there are other agencies that are like, hey, maybe we can start providing primary care. Maybe we can provide access to dental. I had a conversation with Stephen Jeffers over at CTC Bellingham several weeks ago. I mean, I have students who are placed all over the place. And so I get an opportunity to talk to a lot of directors, and he was saying that they're looking at adding primary care and more behavioral health in the near future. So that's it. That's all I got on this topic. Thanks.
Thank you, Tori. I'm so glad you shared all of that. That's so important. I'd hand it back to Brian and Stephen. I think it was your invitation to share, and if there's anything you wanted to make sure if we didn't cover something you were hoping, Stephen, and hand it back to you, Brian, for facilitating.
One question I had is how can we promote this more in the community to various providers? Because my understanding is that they still, you know, they have some space there. So any ideas for how we can, and I did, you know, Leon, John, I made up a little flyer yesterday that's going to be sent to you, but, you know, and they have cards. They have a lot of like business cards, I think, that they hand out. But I'm just wondering if the group has any suggestions for how we can further publicize their services.
Or
I have a comment about that. I don't know what the capacity is in Whatcom County for methadone is. Because I know they're not at capacity. I know CTC is not at capacity. And so oftentimes capacity is dictated by staffing. But The one area that I don't believe is really well served is going to where the people are that need it. Into the camps, into the areas. The providers all are aware of services. We utilize it. I don't know if their clinic can move around. But there might be a capacity question. But also, how can we take it to the streets, I guess.
I'm happy to speak to the efforts that have already happened, and I think awareness is always key. I think that a new service, it takes time for word of mouth to spread, which is the primary way that people are going to access and trust a new service in the community, especially when they are struggling with addiction and substance use. What's been really great is that Leon and Chris and Dr. Parent and others have been able to join many meetings of providers over the past 4 months. And in addition to that, Leon's been able to do ride-alongs with almost all of the outreach teams across the county. And so that is him going into the camps with our different outreach teams and being able to we have some really great flyers that are just have all the information. I think it's just going to take a little bit of time. And when, people have a lot of fear around starting treatment, even when it's not inpatient. And so that trust, we see the Digwalich van comes through the way station parking lot almost daily. And, there's a space that they can park across from the bus station. So it really is, we just need to continue to make sure that people know about it and know what the options are. And I would say we have a variety of providers. So Digwalich does something very specific, but Cascade Medical Advantage, Ideal Options, CMAR, Community Health Center, Unity Care, Lummi. So Digwalich is one of many providers, and I know I probably missed a provider in there. What's so great about that is that clients have choice, right? And now we have a new choice. And so we just need to make sure that the word is out. And I would have to agree with Tori. East County and some of our more rural areas are really where outreach needs to be done. And so connecting Digwalich with the outreach teams that are out in those areas. But again, we have a lot of concentrated services near Bellingham. And so just continuing to make sure we recognize the outside of Bellingham areas.
Yes, Arlene. Oh, Arlene, you're muted.
It seems to me that we had a very inspirational morning, and I am especially stirred by that. It was beginning to feel a little bit on the negative side. And I read this morning that there was a fund for the police of a lot of money from the state to get more police, which of course I support, but how important is it that we get at the cause of the difficulty that people have that puts them in prison? That's why we're here in the first place. And many of us are motivated like that clinic. And so I feel inspired by you all and you, Heather, for the way that you talk and the way that you present things. And I do feel hopeful about it. And I was needing that.
Thank you, Arlene. I think I share your views here in these troubling times, that here on the ground, meeting people where they are, providing a true kind of wraparound approach is very inspiring. So thank you for all of you who toured the facility and for sharing your insights. That was a very moving story, Heather, about basically somebody saved somebody's life that day. And That was very heartfelt. So thank you for that. Any other comments or questions? Oh, I see we have two hands up. I'm not sure who was first, but I'll go with Stephen and then Dr. Wu.
Thank you, Brian. I'll be brief here, and I'm a little bit shading into the work group reports because Dan's not here for the Division Street work group, but I just wanted to report from a couple of conversations he and I have had, and Brian got looped in toward the end. I think we should step back a little bit and look at the fact that part of what we're seeing with the introduction of the digitally mobile medical units is not a new story for this work. We saw similar things with the Ann Deacon Center. We thought we had a model. We went way down the road implementing it, and we saw, wait a second, we haven't thought of everything here. There are a lot of things to fix and to tweak. And so the uptake at the outset of the mobile medical units was way below expectations. And the feedback Dan got, and Dan had been the primary contact here, so I'm just passing along his observations, was that we really hadn't paid enough attention up front to the resource sharing, the outreach, the buy-in from other providers making referrals, and that we hadn't really thought about transportation needs if we were going to center this around Division Street. So I can say in general terms that I understand from Dan, the city is looking for another place to park the van as well, not instead of the Division Street location. And certainly the need in the county and the East County would factor into that as well. So as we go ahead with our work groups and the whole rollout of the Justice Project, let's just keep in mind that there are always things, unless we really push ourselves to look at how this might really play out, that there are things that we're going to miss, and we should be prepared and have resources ready to respond to them in a timely way. Because I think that's what we're seeing having to happen with the Dishwali Clinic. It's a good thing. I'm glad you talked about it at your meeting yesterday. I'm glad the outreach is rolling out. I certainly appreciate Melora's point about how trust and information spreads slowly. The transportation and the alternative sites are another factor of this. So just the holistic view of how hard it is to actually put something fully effective into place is a lesson in humility for all of us that we now have a couple examples of.
Thank you, Stephen. Dr. Wu?
I'm not quite sure exactly how to say this, but I think about the land acknowledgement that we started with and the nature of what's happening with Dishwalik. And my understanding is that this is not a transaction or a deal or a contract, but a gift from the Swinomish to this community. And I think philosophically and culturally, there's an important message there that I think it would be helpful for us to reflect on as we do this work.
Well, thank you for that. Yeah, it is truly a gift. Is there more? Do you think there's something we should do or could do?
I don't know that I'm in a position to elaborate more on that.
Okay.
It's a thought that I'm still exploring, but I do know that there's only one set of people who have lived sustainably on this land for tens of thousands of years. And probably it ties to what Stephen said about humility.
Well, that's certainly something we should all continue to reflect on, and thank you for that comment. Is there anything else related to the Wellness Center before we move on?
I just have a quick comment about what Stephen said with regard to being really thoughtful and mindful about how we roll these out, and Melora's comments about trust from the patients. And then Dr. Wu said something that I think is really important. But one of the biggest challenges that treatment centers have is being in the community and serving community members in a not very pretty disease. Neighborhoods hate treatment centers near them, and they will fight tooth and nail. And so some ground, in true social work fashion, a lot of groundwork needs to take place in bringing communities in to conversation. And while we have that somewhat here in this type of forum, the having more conversations with communities, trying to go to them, not expect them to come to us, but to go to them and say, what are your concerns and how can we mitigate them? And so that does require a lot of different services being in place with that. And here's an example of that is this. The Birchwood area has really, they weren't happy with CTC Bellingham moving in. And I know some of the folks who live over in that area, and also who also have businesses over in that area. And I've talked with CTC about how are you guys addressing this? And how are you meeting the community? And so it's just simple things like if someone is in your yard or you think there's an uptick in crime, maybe we need to look at how we can deploy more resources to help out with that and to provide, and maybe we're already doing that, but to just sort of be more visible about it. And oftentimes in the beginning, it requires an awful lot of energy to go there. When we opened up the treatment center at CCS Treatment Center over there on Lakeway, we came over from where the hospice center is now off Douglas. And we spent a lot of time talking to neighbors. We spent just socializing, going over, how's it going? If there were beer cans thrown around in the alley, we were picking them up. There's some real organic kinds of things that I think we need to consider. Anyway, I'll stop talking. Thanks.
All right, thank you. Dr. Wu?
Sorry, left it up.
You're muted.
Sorry, I just left the hand up. I thought I put it down.
Oh, okay. All right. Okay. Why don't we move on to our next agenda item, which is the work group check-ins. And I think we'll go first with the data group. And I think either Dean or Cedric were going to present on that.
Yeah, to move now from a fairly sublime conversation to a more mundane. The data work group has met 3 times. At its second meeting, we worked on fine-tuning kind of a charter for our work so that we were all clear about what it was we were going to be working on. And Cedric, do you want to just summarize where we are with that charter at this point?
Yeah, I think what I would say up front is that it's near finished, not totally finalized, and our intent is to present it and get approval from this group. So I'm not gonna kind of read the whole thing or go into too much detail, but we wanted to define our scope of work and what we think is our task here. And one of the things that I took away from the meetings we've had in the group, and also our last meeting with this committee where we shared some of our initial work, is that data is almost like an infinite subject, and every single person and service provider and community member will have their own really important perspectives on data and data needs. So, sort of our first focus and point of business is to be, working with Julia, the Village Reach consultant, around the JPIP evaluation and performance measurement plan. So, we've met with her. We want to be kind of a sounding board to help kind of workshop some of the ideas that she has, also understand some of the challenges related to data collection, and then also get a real handle, or try to get a handle on what are sort of the data collection and reporting systems in the county and other relevant systems, rather than come up with a set of measures and say, the data work group says we should track these 10 things, really as a baseline, trying to understand what can we report, what are some of the challenges, what's working, what's not, again, working with the county staff and with Julia. And then ultimately, we think that, we intend to develop a set of recommendations that would include some measures, likely, as well as some considerations around communication plan, how and what and when and where do we share with the county council, with the executive's office, and then with the general public. So those are kind of big ideas. Anything I missed there, Dean?
No, I think the first task really is to make sure that Village Reach is able to complete its work by the end of June, which is to produce a measurement and evaluation plan. And then I think we view our role also then to be present beyond the end of June when they deliver that
Yes.
plan to help move its recommendations forward and try to highlight the kinds of resources that are going to be necessary for the county to actually be able to collect and report and use data that would measure the effectiveness of the work that's being done in the project. So I would say then, as Cedric alluded to, we had a third meeting just this past Friday, which brought the work group together with folks from IT and to really go through in a bit more detail what are the various data systems that are in use within the county across the various players in the criminal legal system, as well as the human services area that are relevant to those involved in the criminal legal system. Julia, I've provided her a copy or a recording of that meeting because she was unable to attend, and I think it will be helpful to her to get a greater understanding of the various data sources. Then we'll come back to this committee and legal and justice to basically present our charter for final approval so that we know what we're doing is what you want us to do.
No, I think a charter is an outstanding idea, and it makes me think that our group on diversion and reentry should develop something like that too. Any other comment? Dr. Wu, you have your hand up.
Yeah, I wasn't here last month, so I just wanted to check, but I'm hoping that whatever data requests we put in are as much as possible, or requiring that it be possible, that information be disaggregated by by categories that are subject to discrimination.
Absolutely. That is, in fact, in its current draft of the plan, which Julia is still filling in the pieces to, that disaggregation by both BIPOC and behavioral health subpopulations is very much a part of the plan.
And I would just add there that kind of related to what I said broadly, also understanding where there are challenges or limitations there. So some of that was raised last month. Some of it's been raised in our work group meetings probably every time. And so wanting to be clear and explicit about, where there are cases where we'd like to capture this and here's the limitation, or here's why we don't, with the goal of capturing and reporting, the categories that we think are most.
I just have to comment that where we can't or where we don't is often in the service of maintaining oppression.
In
Right.
service
So
of maintaining what? I'm sorry.
it is for the purpose of maintaining and supporting continued oppression.
Hmm.
So I think when data can't be collected, sometimes I think that's an argument for questioning why it can't be connected and who's that serving. And I'm hoping also that disaggregation by sexuality and gender identity is also included.
We'll pass that suggestion on to Julia. I think she had been focusing primarily on BIPOC and behavioral health disaggregation, but I'll pass that on to her. I want to say that the trajectory of her work has been to, first of all, work with key stakeholders and reviewing best practices in the literature and so on to develop what we would ideally like to measure. And then now she's beginning the work of going back and looking at, okay, given those things, what capacity do we currently have to generate the data elements that go into calculating each of those measures? And of course, what that implies is that there are going to be gaps between what's available and what we'd like to have. And so I think one of the things that the work group feels responsible for is not simply having that report left on the shelf, but in fact being then sort of the ambassador for describing what resources need to be allocated to move from those gaps to actually being able to generate those kinds of data. And also, as Hedrick mentioned, to communicate it well at various levels, including with the broader community.
Stephen?
Thanks, Brian. Yeah, I wasn't the reason why I raised my hand, but I want to applaud Dean's and Cedric's focus on that gap analysis and using that as a roadmap for further implementation. I think that's just a critical piece, and I'm so glad to hear you articulate that. The reason I raised my hand was to add my support to Dr. Wu's last comment about gender identity and gender straight out, because if I'm remembering correctly, that was one of the areas of disparity that the original Vera report pointed out. And so I think that's something that we need to keep our eye on and we need to track is how that, and I won't use discrimination, I'll use disparities because that's what they used, but those differences should be things that we pay attention to.
Thank you, Stephen. Pam? Pam, you're muted.
Thanks. I might be kind of behind the 8 ball here, but I'm not sure what we're trying to measure. Are we still trying to determine what we're trying to measure, or have we decided what we're trying to measure?
Yeah, there are really 3 levels of measures that are being looked at. The first level is really more process measures related to each of the 15 projects. Are we doing what the project said we would do? And where are we in terms of the completion of that particular project? Then in terms of the next level, sort of at the systems level, the measures have more to do with outcomes for the populations that we intend to serve in our various strategies. And there are 4 major ones that have been identified. One of them is just jail bookings and what kinds of changes in jail bookings are occurring over time, and particularly disaggregated in the categories we've talked about. And then jail length of stay. The third one is connection to services in the community, to the extent to which people leaving the jail are able to connect to and benefit from services being provided in the community. And the fourth is what's the recidivism rate with respect to people who have been involved in the criminal legal system. And again, each of those disaggregated by the categories that we've talked about. And then at the community level, the measures they're really population measures that are not unique to this particular justice project, but to what extent is the health of the community being improved? And there are all kinds of measures in the public health world, in the public domain, to point to. And then to what extent is the community safer as a result of all the efforts that are being made in the justice project? And there's still work going on to detail out, particularly now more at the process level, what measures do we need to have? And Julia has been constructing a table of both who are the clients and what are the measures for each of those 15 projects. And that's a work in progress.
Thank you. Appreciate it.
Thank you. I'm mindful of our time here. So maybe if there's not anything else, I'm going to move on and talk about our diversion and reentry work group. We've met twice, most recently yesterday morning. And Alexis is going to talk in a minute about some issues related to ankle monitoring and whether that person is considered to be, in custody or not, and its effect on Medicaid. We talked about a number of different issues yesterday, particularly options for different diversion options between arrest and charging. Also, it was mentioned that we thought to really move forward on a number of issues, we would like to have a representative of the prosecutor's office be a member of our work group. So that's something we're going to be pursuing. I and Dan pursuing adding a member. Also, there was some discussion that we would like to identify best practices in a number of these areas, particularly reentry, best practices in other jurisdictions in Washington state and perhaps nationwide, and identify and see how we might apply those to Whatcom County as a way to kind of focus our work. And we also talked quite a bit about the transition with the issues related to the way we contract for so many services related to the timeline for the Medicaid waiver. And we found that that's, Hannah can talk about that in a little bit more detail if people have questions. But the issue there is that other jurisdictions who have their own staff running those programs seem to be on a little bit faster timeline than we are here in Whatcom County with the Medicaid waiver. So given all of that, our committee decided to take a little bit of a hiatus, and I volunteered to do some research on some best practices, and we're going to reconvene in a couple of months. So, but we do have something we think is actionable right now, and I'll turn it over to Alexis to explain that in more detail.
Thanks, Brian. Good morning, everyone. I'll keep this brief, and then if you have any questions, please feel free to follow up. So one of the items that we were looking at, there's an issue currently where if an individual is on ankle monitoring, their Medicaid coverage will immediately be revoked or paused. We need some clarification as far as how soon does that happen. It appears that it may soon occur more immediately than originally anticipated. And then there's a cutoff point as well. And I believe it's 30 days, but I'm waiting for a response from a contact at Molina. There's a cutoff where if the individual doesn't call to reinstate their coverage and to explain that they're on an ankle monitor, they're not actually physically incarcerated at the jail, that then they have to go back and reapply for Apple Health. And this was one area that came up of interest for some actionable items, in particularly related to reentry services. So can we take a look at the barriers that are already happening within the community that could be enhanced and improved upon. And so some other components that came up from that conversation, Hannah mentioned that the data comes from the JBRS, which is the state's jail booking reporting system. And then Dr. Wu suggested modifying the roster list to more clearly separate non-physically incarcerated individuals with those ankle monitoring. When you pull up the jail roster, it will say if someone's on an ankle monitor, it'll say electronic home detention, but there appears to be this disconnect between the data that the MCOs are receiving and the interpretation of that data in relation to the specific. So why does this matter? Well, then we want to look at, does the Medicaid waiver then apply for these folks? And is that something that would then fall in the jail, to hit that magical button, if you will, and make sure that their insurance is active. So when we're talking about continuity of care and keeping folks connected to services, this is a vital piece and something that I think has been experiencing a lot of missed opportunity in the last few years or so, if not more. So happy to answer any other questions about it.
Any question, Stephen?
Alexis, could you break out? I mean, when you say ankle monitoring, there are multiple different kinds of ankle monitoring. And I wonder, are they all treated the same by the Medicaid managed care organizations? Or can you break out the differences amongst them?
Yeah, as of right now, what I've seen, just in experience as a clinician working with folks that are on ankle monitoring, it doesn't seem to be that the MCOs are really differentiating between the different types. And that's where the issue is happening. You might have someone that is, their parameters with their ankle monitoring are specific to them remaining in their home. But you may also have someone that is able to go out into the community, access the services they need. But when they go to access those services, then they're being told that their insurance is not active and now they can't access the service. That's part of their probation requirements. Where I saw this most often in my time in outpatient services was when folks experience like a probation violation is an example. So maybe it was a missed court date or some other violation, and they would temporarily be put on ankle monitoring for more closely monitoring, but then they would go to their group at the treatment center, or they'd come in to complete an assessment, which is another requirement of their probation terms. But they wouldn't be able to because all of a sudden their insurance is saying they're not active. And so that's what I want to get some more specificity around from the MCOs on how are you interpreting this data, and is there a better way that we can communicate it so it's more clear whether or not this individual's insurance should actually be paused at this time.
If I could just interject as a former legal aid lawyer who did years of Medicaid advocacy, there's an appeal process in the Medicaid program, and some the MCOs aren't too subtle about how they implement their contract, and HCA doesn't monitor their compliance with Medicaid law at all. So there may be some questionable practices that you see that legal advocacy from a lawyer or even a non-lawyer could change that policy, at least for an individual. So if that ever becomes an issue, I'd be glad to try to think through that with you or Brian with the whole work group.
Yeah, I'd love to connect with you more about that. Thank you, Stephen.
Yeah, and even though I said the committee's going on a brief kind of hiatus, I think I will continue to work on this issue in the interim, because I think there's changes that could and should be made here. So Tori?
Yeah, thank you for that report, Alexis. I'm very what has the ombuds office weighed in on this?
I don't think I have that information at this time.
You're talking about the state behavioral health ombuds office? Yeah. Well, Alexa, you and I can check in on that because I met some representatives from that office at NAMI's Washington's annual conference last summer, and I know they're pretty busy, but this sounds like something that could be in their wheelhouse. So, okay, any other questions for Alexa or on the diversion reentry work group?
I'm not quite sure how to help you with that.
All right, let's move on. Dan is not here, but the Division Street work group is the third group, and I don't know if anybody on the call is a member of that group.
Yes, I'm a member of that
Oh,
group.
okay, yes, go
Yeah,
ahead.
and I was, yeah, and so am I, and Dan asked me to report out.
Oh, okay.
So we worked, well, we met one time to talk about, just to brainstorm some ideas about how the work center can be utilized once the jail is completed. And we had several ideas that members brought forth, sort of kind of keeping in mind the area, the neighborhood, how to partner like with entities such as like the Humane Society. But there were several ideas, and so I talked about what would a social enterprise for a recovery campus look like out of the uh, center. And it would be like a short-term transitional housing for folks waiting to go into treatment but who don't meet criteria to be in detox. And then also a short-term transitional housing for folks who come out who don't have a landing spot. The nature of the social enterprise is that it could fund itself so that we wouldn't have to rely on grants, tax dollars, billing Medicaid. Just as an example, a local thrift store. If you had a thrift store or some other type of business in there, there's a local thrift store that brings in $11,000 a week. So I think there's some ideas there. The other thing was really building out a satellite clinic with Bigwell Leach, with more medical services, support meetings, having more dental services, etc. Another idea was the 23-hour sobering center, in which these are often co-located with detox centers or crisis centers. The thing about the 23-hour sobering center is that you have a little bit of time for people to sort of get the chemicals out of their system long enough so that they can make better decisions or have clinicians work with them with the stages of change to sort of help them go into treatment services. And an evaluation and treatment facility, or a type of behavioral health urgent care, which would help to reduce the amount of emergency department admissions or contacts, and then maybe long-term transitional housing with supported services embedded. I know that if you talk to anybody who does residential treatment services, if there is no good landing spot for folks, they tend to not do well and end up coming back through. So I think any kind of resources that we can put forth to this is supporting that will help to support the overall medical system. And Arlene, what I miss?
No, I think you did a very good job of it.
Okay.
Oh, I think what stood out for me as a surprising addition is the idea of a business supporting the operational expenses of, let's say, a clinic or the services on that space. That is a very creative idea and has possibilities, I think.
Well, thank you, Tori and Arlene. Any questions?
I just wanted to also throw out there that most of us have heard of Sundown M Ranch, and over in Yakima, or close to that, in Sela, and Sundown M Ranch. The reason why they can provide treatment services, residential services at such a low cost is because they built up they were like a social enterprise with their publishing center. They published a lot of recovery materials out of there. So anyway, yeah, that's it. Thoughts, questions? Can we add to this list? Do you guys have an amazing idea we should consider?
I think that's an intriguing idea. And but how big is the physical footprint out there? Do you happen to know? I'm just curious.
Let me look.
I think it's I don't know the exact measurements, but I remember it's 2 lots wide, and one lot is occupied by by several buildings. And so we were able to look at the maps of how the buildings were laid out and how additions could be added to the footprint.
Yeah. There's a lot of different options for how that could be, reconfigured going forward. So in the interest of time, Alexis?
I just have one quick question that may be more clarifying. When you talk about some of the more outreach-based services and maybe mobile units, I'm wondering if there would be an option for Deidrolic or another provider to offer some kind of outreach-based dental services, similar to what Unity Care does with the kiddos in Whatcom County.
I don't know who the question was for. Was it for the?
I guess it's more so a thought or a recommendation if we're taking this approach of outreach and getting more into the streets, as you mentioned earlier. I think it would be great to see something like that, and if that's a model that Deidrolic has considered, or maybe is already doing somewhere else.
I don't know, but we used to have a mobile dental clinic come to PCN on a monthly basis. And I'm not sure where that's at now. Maybe Melora knows.
Yeah, we actually have a new service, and they have been working on funding for the last year and a half. So it's not something that they've fully been advertising, but it's a agency called Dent All, ALL, and there's not a chat, so I can't put the link in here, but Dr. Jessica Duback, who is a dentist, she's actually the dental provider in our county jail. She's started this business, and it's a mobile dental clinic for adults. And I know she's already working with East County and kind of ramping up services. So very exciting. And I know they're getting close to being able to show up in meetings and talk about how to make referrals, but they also know they're going to be overwhelmed. So if you Google Dent All Whatcom County, or I think it's wearedental.com. So very exciting, and would really meet that need. And Dr. Duback has a really incredible vision for that.
Thank you, Melora. In the interest of time, if there's nothing else, why don't we move on to our presentation by Mike Hilly, monthly overdose statistics. And Stephen, do you know roughly how long you think you will need to present on the advisory committee?
I think it can be very brief, and thankfully I have Melora with us also. So
Okay.
I don't know, maybe just 5 minutes. We'll
Okay.
just give you a cursory overview of what we're looking at in the
Okay.
next.
Okay, Mike, with that in mind, I'll turn it over to you.
Yeah, thanks. And I'll share my screen real quick, and I'll make it quick. Hope everybody can see that okay. And that most everybody's familiar with this. This is our look at the overdoses by month, going all the way back to 22 there, and you can just kind of see how that tracks up. So we've seen this slide before. This is the one that really is more dynamic, and so this is up to date from May 13th. We're still with our 3.0 average, although it's down from 3.4 to 3.0. But this has been what's going on here and for the month of May. We still had those jumps towards the end of last month, but yeah, our 3.0 is what we're sitting at. And just another way to look at it, this is our comparison from last year to this year at that 336. So we're about 5 months into it here. So we're tracking similar as last year. Be interesting to see what we end up with on that. Just another look at our responses, year-over-year trends. This is just another way to look at those couple of graphs that I put up through there. And then this is those time periods from year to year as well, just the opioid versus non-opioid overdoses. Then this is related to how much Narcan we're giving out in the community. Some of this is given prior to EMS arrival. In fact, a lot of it is given prior to EMS arrival. In fact, comments over the years has been the bystanders are passing out more Narcan out in the streets than the actual EMTs and paramedics are on those given calls. And so, but this is relative to our Narcan Leave at Home efforts, getting Narcan out to the community. And you can see this 59% prior to arrival is a pretty good number of people getting Narcan before they call 911. So it's a good program, saving lives. Here's some gender profiles up to now, and I always look in this area here and wonder what that's about. Sometimes it's medication errors, etc. Other times not, but I just think it's interesting as we look at the demographics over the age continuum. And then these are places where people are overdosing, by large single-family homes, but this big slice here for the unhoused is a major contributor as well. And then apartments, really kind of one in the same apartment versus single home loan, but still a large amount of the unhoused. And then this is from the emergency department. This is, I grabbed this off the Whatcom Overdose Prevention website. And this is showing the emergency department visits through end of March on this particular slide. So, yeah, still tracking up that 75 to 80 visits in that population there. So, and then these are overdose confirmed deaths. This is a compilation from the medical examiner's office. Once again, grabbed off that Whatcom Overdose Prevention site. And this is by toxicology, by the way, too. So these numbers come in after the ME has determined that cause of death via toxicology for drug overdoses. Overdose death by population per 100,000 and age and sex, too. So once again, here's your age continuums and then your demographics to age and sex. Specifically higher among these age groups right here as compared to others. And then this is just another look at Washington State as compared to Whatcom County. And so from what I could tell on this, we generally track what's going on at the state level as well in our county. Probably no big surprise there. And then this is a look at overdoses. This is actually from Washington Emergency Medical's Information System. So this is a regional look at the type of overdoses that EMS is responding to. So, you know, the statewide numbers, that 1794 total, combining all of these numbers. These are has a lot to do with data completeness, too, on how those opioid calls are defined on the reports that the EMS sends in. So we actually have a pretty good high rate of data completeness on those reports from EMS, our patient care record system from EMS. And just another way to look at what we're responding to. This is the improved Narcan, usually prior to arrival, and then the suspected overdoses in those total unit responses, and then suspected overdoses is charted. And usually those are charted various ways because you don't have the toxicology on scene, but usually that's documented with paraphernalia on scene, somebody saying they saw somebody take a narcotic or using with others. We'll see that reported in the narratives as they write their patient charts. So, and this is just another look at comparison of the naloxone response, Narcan response to the opioid response, and then once again our data completeness records that capture that 98%, which is a good data completeness capture actually. So. And I shot this in. This is a comparison of county. Our county is not in here. But I do get this from the King County Medical Examiner's Office for all the participating counties up the I-5 corridor. And this is just a comparison to other counties of their rates of overdose, always also overdose versus other or narcotic overdoses versus other types of overdose. And another way of looking at that, yeah, you can see Yakima kind of leading the charge down there all the way down to Kitsap for those 8 counties that are reporting, and that's a rate per 1,000, 100,000, by the way. And then just a little bit of a look at what's going on in the state. The dark spots being in Seattle, it trims out up here in these overdoses per 1,000 in this sort of heat map that's looking at here at this. So I wanted to kind of show you something. This was interesting. It caught my eye last week. So the patient care record system, 2 of the most primary patient care records systems in the U.S. is a company called ESO and Image Trend. We use Image Trend in our community. But as a nationwide look at these metrics in patients with overdoses, ESO, because they look at 12 million records here, from across the U.S., and they have noticed a 20% decrease in overdoses as reported through the patient care record system from EMS. And that was tracking similarly with our Image Trend information as well. Now, Image Trend hadn't published that information for us yet, but we do know that it's a very similar. Watching a presentation by Image Trend here a couple weeks ago. And then on a side note, that kind of trends with are consistent with some news reporting I heard earlier in the week. I don't have the source, but one of the headlines on the National Evening News was that the overdose rate had gone down by 26% in the nation. So a little bit hopeful there. You see it in the numbers. And I just thought it's interesting that we're able to take this national look with all the patient care records generated by EMS and be able to trend that down. So that's the report for the month. This package was included in your slides. And then also in the package, I included a very thick report from the King County Medical Examiner that has a lot more in-depth information and intelligence, if you will, on what's going on out there. So that's all I got.
Any questions for Mike? Dr. Wu?
Mike, do you think that it's great that there's so much Narcan being given prior to EMS arrival, but there's still a gap there. And do you think that's an opportunity where we could save some more lives?
Well, yeah, absolutely. In fact, that 61% of Narcan prior to 911 arrival is a significant number from my perspective. And then I also wonder how much Narcan was given where they didn't call EMS too. I know there's a number in there. So, and as the narrative changes, and this is what's on my mind with the new Digwallic and the MAT providers, which is, and especially with buprenorphine coming on, how can we do a better job of letting people know that, yeah, they have a life-saving drug in their hands, Narcan. Great job. Thank you for resuscitating that patient. But the next step is that you're in precipitous withdrawal. That's going to keep you sick. So how can we message to people that we have a treatment in the emergency department or at the Digwallic or at the Ann Deacon Center to bridge you into? And I think that's the next piece of our outreach is understanding that, changing that narrative, especially with the buprenorphine coming on board with EMS in the field. So
that seems like a really big
opportunity.
Yeah, that seems like a really big opportunity coming right up.
Yeah.
Any other questions for Mike? All right, hearing none. Stephen?
Yeah, thanks, Brian. I'll just keep this at the 10,000 foot level because time limitations, but I have the honor of co-chairing the Behavioral Health Advisory Committee for the Health and Community Services Department, which has been in place for a long time because it's charged with advising the department on the use of the 0.1% behavioral health tax, which far predates the additional tax that we adopted for the Justice Project. So mostly servicing Response Systems Division in Melora. But one of the key features of that 1%, 1/10 of 1% tax is how thoroughly the department has braided that into a lot of services that touch on behavioral health, but aren't exactly behavioral health, housing support being one. So we had a presentation at our meeting earlier this month from Kayla Schott-Bressler, one of the deputy county executives, Ali Panucci, the other deputy county executive, and one of their contracted consultants, Doug Milliman. They are working, they are scrambling, they are feverishly trying to unravel the revenue shortfall and the budgetary problems that the county as a whole has, but that impact that 1% of 1% behavioral health fund. We had a large surplus just 2+ years ago. We decided we didn't want to hold on to that when there was so much unmet need, and a lot of that was contracted out. We're now projecting that we can fulfill those contracts based on the dive in revenue intake from because it's sales tax based. So the county is planning short-term interventions, but Melora, and I'm trying to assist with this, is looking for advice from the BHAC on possible prioritization of behavioral health support throughout the community. A pretty grisly and dismal task, but probably necessary. And we're looking at out years, 2-3 years out as well. So we got some baseline numerical information from the county staff. Our intention, we meet every other month, so our next meeting is in July. Melora is working up what we hope is a facilitated process where the committee members will be able to work through some priority recommendations. The reason I'm reporting it here is because so much of the behavioral health stuff is siloed. I talked about braiding the 1/10 of 1%. Some of that plays into Justice Project projects as well. So we figured we ought to start communicating across committees. And so we're here just to tell you that that's the process we're doing, that we're up the creek a little bit with funding for some of these things. They will probably involve some effects on Justice Project implementation projects as well. And we'll try to give you periodic reports on how that process proceeds. Melora, did I leave anything out?
No, that was great, Stephen, but I'm happy to answer any questions.
Thank you.
I just had a real quick question on what it generates, how much annually, and what's the current fund balance or sort of reserve fund component of that?
Yeah, Brian, we only have 1 minute left.
Yeah, okay, sorry.
And that's a very in the weeds question. But historically, the fund, depending, because it is sales tax based 100%. And so, we've seen revenue between, 4 to 7 million. And we have a lot of annual commitments. There's a lot of programs and many contracts across the community, as well as programs in the Response Systems Division. And so what we know and what we're trying to correct for is the structural imbalance that we have by the end of 2026. So without shifts right now, by the end of 2026, we are in a negative place. And we're also required to have a healthy fund balance at all times. That's part of being able to have a sales tax like this. So, as we have a lot of internal work to do, and as Stephen mentioned, the July meeting of BHAC, we are hoping to come away with clear priority areas from that advisory committee so that the health department and the executive's office can feel confident about some of the decisions that we have to make.
I'm sorry for asking this. Yes.
No,
So-
no, and the information from BHAC is public, and so, you know, we're absolutely able to share that. It's just, we spent probably 70 minutes on just that question at our last meeting, so.
Okay. So finally, I don't know if people have had a chance to look at the agenda items for our next joint meeting with Legal and Justice Systems. Does anybody have any comments on any of those? Okay, any good of the order? Okay, with that, thank you all for your time. This was a very good meeting. I learned a lot from it. Thank you to all those who presented. And
Excuse me,
we'll
Mr. Chair, I just want to say for the record, we don't have any public attendees today,
Oh,
so
okay.
there aren't any public comment.
Oh, sorry. Thank you, Jill.
That's
Thank you,
okay.
Jill. Okay. All right. Well, the meeting's adjourned. Thank you all.